Hi, everyone. A very warm welcome to the webinar. We'll get started in a moment. Please, can you write your name and organization in the chat? Really great to see the participants and looking forward to starting the webinar shortly. Thank you. Okay. Good afternoon and good morning, and a very warm welcome to the webinar. It's really great to have you here to be part of this session. We're really excited to be hosting this webinar as ITPC Making Waves and Salamander Trust. My name is Wame Jallo, and I am the Director of Global Programs and Advocacy at the International Treatment Preparedness Coalition, and I'm based in Gaborone, Botswana. And with me are my colleagues who will, during the course of the webinar, introduce themselves, but also share the various presentations. Just to share some logistics on the webinar process, can you kindly introduce yourself in the chat, put your name and organization in the chat function. There is a Q&A box at the bottom of the panel. If you can type your questions in so that during the Q&A session, the answers can be addressed by the questions can be addressed by the panelist. Just so that you also know, this webinar will be recorded for dissemination purposes and shared also on Facebook Live at ITPC Global Facebook page. So we're really excited to have you here. The title of the webinar is Confined by COVID, Women, Girls, HIV and Sexual and Reproductive Health Rights Issues. This webinar is meant to cover all of the findings and feedback that you hear from women in the community in East and Southern Africa on the effects of COVID on women living with HIV and also vulnerable to HIV, and also to initiate and to facilitate a discussion and dialogue in terms of what are the different types of advocacy and change that needs to happen in the various countries to ensure that services, treatment access gaps, policies, and issues that women face on a daily basis are addressed at both national level, regional level, and global level as well. So we're really excited to get started and to welcome you all to this session. Let me start by introducing the panelists who are going to be speaking. We have 4 women who will be providing a presentation on how COVID has had effects within East and Central Africa. We have Joyce Omana, and Joyce is a 24-year-old woman who's living openly with HIV. She's passionate about representation of adolescents and young people in decision-making spaces. She's currently an AVAC 2020 fellow in Kenya, which is a project advocating on effective HIV and sexual and reproductive health integration advocacy around preparing Kenya for the new product introduction. With us also is Jacqueline Alessi, and she is with Making Waves. Jacqueline is a 33-year-old, self-driven, committed young woman living openly with HIV, and she's passionate about working with young people living with HIV. She's contributed actively to the HIV/AIDS response nationally, regionally, and within the local communities and globally. She's the former executive director of Uganda network of people living with HIV, and she has now stepped down to lead another organization called Jacqueline Susie Foundation. With us as well is Diana Allison, and she's also with Making Waves. Diana is a 33-year-old years old, and she's from South Sudan. She's the founding director of Young Positive South Sudan, which is an organization that works with adolescent girls, young women living with HIV in South Sudan. And she has worked for more than 8 years in the areas of gender equality, specifically on women's rights, girl child education, and champion campaigns to end early child marriage in South Sudan. We also have Martha Tulani, and she's a feminist and activist and advocate passionate about women's issues, rights, access to basic services, access to HIV-related treatment, functional HIV systems, environment, and conservation issues. Martha is keen in clinical research and serves on a community advisory board for the University of Zimbabwe Clinical Trials Research Center, AIDS Clinical Trials Group as well. We're really excited to have these panelists join us today, and they will be sharing with us the views and outcomes of the research that they have been working on over the past 3 to 4 months. And we're really excited to have them on board. Please note that their presentations have actually been pre-recorded by audio, and we really want to thank the women for having done that in advance due to, unfortunately, internet and challenges with connectivity. It was better for us to actually do the recording, and then we'll have them speak live and answer the questions during the Q&A. So with no further ado, I would like to share the presentation and start with some remarks from Joyce. Thank you.
Hello, thank you very much for giving us this opportunity to present on how women and girls living with and affected by HIV in East and Southern Africa have been confined by COVID-19. We will talk about the challenges that these women have been going through, their responses, and what is needed in order to address these particular challenges. This presentation is informed by 2 phases of research that was conducted by Salamander Trust and Making Waves Network in support and coordination from ITPC. Next slide, please. On this slide, I would just like to give a brief background on the 2 phases of research that were conducted and that have given us the feedback that we're presenting to you today. So for the first phase of the research, which was conducted in March 2020, it was done specifically for presentation at CROI. This first phase of the research was done before COVID-19 became a pandemic, and it included 198 women from 28 countries in East and Southern Africa. And among the key stakeholders who helped in gathering this information or in this research were partner agencies such as ICW East Africa and AfriCaid. Among the research methods used were surveys, interviews, focus group discussions, and literature review. The second phase of the research was conducted in October 2020 during the COVID-19 era, almost at the peak. And it was basically prompted by the results of the first phase of the research. It included 30 women from 10 countries in East and Southern Africa, and was basically a rapid brief research. And it included a cascade interview approach with the 30 women. Next slide, please. From the first phase of the research, we had some very strong quotes from the women or from the respondents who took part in the research. One respondent was asked, "Who supports you?" And the answer was very heartbreaking. She said that nobody supports us. We are supported by our passion. Also, some of the women respondents reported a gap between their experiences and the friendly, safe, supportive, and non-judgmental services that they seek. Such services would ensure that all women are able to access sexual reproductive health and rights without experiencing any institutional discrimination and violence. But it was sad to note that peer support provided by women and their organization is often the only avenue for such non-judgmental care, and that simply means that we have a long way to go when it comes to how we are offering our health services and to women living with HIV. The women who were consulted also pointed out that they have repeatedly made all the recommendations listed below over decades in many successive documents produced by women living with HIV, but nothing much has been done and nothing much has changed. But then I guess that's what advocacy is all about. We push and push and push until there is a way forward. Next slide, please. Among the key quotes from the October 2020 research, which is the second phase of the research, is that one of the respondents mentioned that COVID-19 has just made an already bad situation worse. Adolescent girls and young women who are not accessing services before COVID-19, they are most definitely not doing so right now. And COVID-19 has only aggravated the situation. Women were exposed to violence before COVID-19. Young women were not getting information, commodities, or even services before COVID-19. But because COVID-19 is here, we have found the big black dog to put the blame on. And that quote still remains true, up to date. Next slide, please. So, among the issues that the women and girls who took part in this research, among the issues that they mentioned that have really escalated during this period is violence. Adolescent girls and young women and women in general have been exposed to enormous amounts of violence, be it in terms of defilement, be it rape, be it intimate partner violence. There has been an increase, a constant increase in such cases. Adolescent girls have reported being raped by brothers and fathers. Intimate partner violence is very rampant and has also increased over this period. Basically, could be due to the worsening economic situation and the lower frustration threshold that is bringing in a lot of intimate partner violence. Unfortunately, during this period, police have not been taking reports as they say that people should stay home because of coronavirus. Therefore, access to justice is denied while women and girls still remain in unsafe environments where they are continuously violated physically and emotionally. And this is just a sad state of events. Next slide, please. Now, access to contraception has always had a lot of barriers to access to it. Now, this period of COVID-19 has seen access to contraception really have more barriers than it used to before. Currently, even if a woman would want to use contraceptives or just a condom, they cannot be able to access it. So they definitely cannot use it. Access to contraceptives was hard as access to transport was not possible during lockdown, one of the respondents said. For those who did get to the clinic, access to family planning was not the priority of the facility. COVID-19 was. And emergency services were more prioritized. So if you come for family planning, they said, please go home. We only do it once a week. And on that day, they only take a certain number, so you may not get it. If you do, you don't get a choice. That is how bad COVID-19 made the situation worse for women. Next slide, please. Now, this slide just talks about how COVID-19 has highlighted the attitudes of funders that really need to change. Right now, members and communities are more concerned about the welfare. Everybody's concerned about financial security. Everybody's concerned about food security. Everybody's concerned about their sexual and reproductive health more than looking at how to advocate for their rights and freedom. But we cannot blame women for focusing on essential, or rather for focusing on their basic needs, because you need to eat for you to be able to take the medication properly. You need to have financial security for you to even have a peace of mind, for you to be able to provide the food for your family. And we have seen funders still remain very rigid in these situations and still not willing to support or not flexible enough to support women organizations through this period. And even for those that were willing to support, they had such stringent conditions that grassroots organizations could not be able to meet. It was completely not fair. So we have a large number of women. Most of the grassroots organizations work with large groups of women that can actually help in advocating and reaching out to the ground with some of the key implementation strategies. And funders provided or gave a very huge barrier to any form of support to the continuation of the essential work that women and girls organizations do at the grassroots. It is also very key to mention here that funders should stop funding the trend and should just consider that women and girls are going through non-stop issues that do not you cannot afford to work on and leave behind and go and pick on what's trending. For instance, case in point, funders now went shifted to teenage pregnancies because that is where the real the limelight is on HPV and early marriages. That is where, and I feel that this is not fair for women and girls, because half the time you help the donors and funders help with programs halfway and they leave the women and girls hanging. Next slide, please. Now, this thought-provoking slide is just basically showing an empty boat with suckling sharks of HPV, early child marriages, HIV, and teenage pregnancies. But right beneath the ocean, we have invisible foes like sexual reproductive health and rights violation, intimate partner violence, and other violence against girls and women. What's interesting is that donors and funders and implementers are focusing on the suckling sharks that they can see. No one is focusing on the toxic underneath the ocean. No one is focusing on the toxic environment beneath the ocean, where constant violations occur and prevent women from accessing any of these suckling sharks, from accessing any of the interventions that have been put in place to address them. Next slide, please. This is my second last slide, and it's just echoing how COVID-19 has been likened to an X-ray revealing fractures in the fragile skeleton of the societies that we have built. It is exposing fallacies and falsehoods everywhere, and that's more like echoing what what my presentation has been all about. And on this slide, we have our call to action to donors, to NGOs, and to governments. And as you can see, it's an all-rounded call to action where we need urgent support for the work that we do as women and girls organization, and to continue upholding our sexual reproductive health and rights as essential. And for all these other call to action, my colleagues who will speak later will respond to them. Next slide, please. Just before I go to the next slide, I just would like to mention that I know my time is almost up, but I just would like to mention that while everybody can argue that COVID-19 has affected everyone all the same, it is not entirely true. It is women and girls who have endured intimate partner violence. It is women and girls who are constantly trying to negotiate condom use. It is us women and girls who are trying to avoid unintended pregnancies. And it is us women and girls who have had to endure gendered inequalities over time. It is us women and girls whose health choices remain in the hands of our sexual partners. And that if COVID-19 has made everything else bad, you can imagine how worse the situation is for us right now. Next slide. Now, on my final slide, I'd just like to say that my call to action to everyone, to all the stakeholders, is that we should continue to ensure that provision of sexual reproductive health and rights and HIV services during a pandemic is non-negotiable, and do this in ways that feel safe for women and girls living with HIV in all our diversity, especially including adolescent girls and young women living with disabilities. Thank you very much.
Hi everyone, my name is Jacqueline Alessi and I'm from Uganda. I'm glad to be joining you all on this webinar where we're talking about confined by COVID, women and girls. I want to bring on the experience of women living with HIV I interviewed from Uganda. However, the same issues also occurred in other countries that these interviews happened. I want to specifically start by the specific issue of that we discovered that women lacked what to eat during COVID. This was a very big issue. For example, because of COVID, very many women during that time who were low earners lost their jobs. And most of them could not go on doing the petty jobs that they were doing from home to home because there was a total lockdown, for example, in Uganda. But also this happened in many other countries. So because of this, women were not able to move, and also this included the women living with HIV. So, however, the government distributed some food. I want to applaud them for that. But this was something that was not specific to women living with HIV. It was a general distribution of food and not to all people countrywide. So, in fact, we saw this as we saw very many women living with HIV who really needed food as their immediate help that time. So, this kept on happening over and over. So, and it affected very many women who were taking ARVs. Not only women, actually, very many people taking ARVs. And some of them were forced to leave their medicines. And those who could take their medicines, they would take them on an empty stomach, which actually was something very, very disturbing. So as we are planning, I appeal to everyone who is in charge as we are planning for any programs that are related to COVID and HIV. Let's ensure that we have sustainable programs that are going to help women have what to eat just beyond any COVID or any emergency. So let's plan to have programs that are going to support them, like for example businesses, supporting them with livelihood projects like agricultural activities that can help them at least do backup plan just in case any other thing like this happens. So I would really want to have everyone know that this is something that happened, and it's still happening, by the way. So let's have sustainable programs. The other thing that I would want us to note during the interviews, that COVID came with a lot of violence which actually occurred to women. Women living with HIV, even the general women. So this also manifested in a way that especially men who are doing some petty jobs or doing actually jobs like the motorcycle riding, doing a taxi driving. Remember, we're on a total lockdown, so they could not have any way of earning, hence creating a lot of violence in homes. And this is something that we saw that could have been avoided. However much we know that there are very many programs that have encouraged gender-based violence. Have discouraged gender-based violence. We are very sure that as a call and an appeal, as we plan globally, let's ensure that we address and prevent the violence against women and girls globally. This also I would also want to bring attention to the violence that also occurred in facilities. When originally you would go and confide in someone at your facility, but we reach a point where only one person would be at the facility, hence making it very hard for women who could confide in their fellows to be able to to bring up that they needed the medication and all that, hence actually bringing out issues of confidentiality and all that. So as I conclude, we must note that COVID seems to have come down for now, but it's still here. And it is going to come again. In some countries, we've seen that the wave, there are waves that are coming. Some countries are in the second wave, and the others are even in the third wave, or even others are in the, it's really not going anywhere. So let's, we really need to, we really want authorities to plan ahead with us. Let's plan, let everyone plan, while not excluding people living with HIV, especially the women who are actually much affected in issues that affect them. So in this case, I really want to talk about there's nothing for us without us. So let's ensure that every person who is key is part of the involvement. I thank you very much, and I look forward to receiving comments and questions.
Hello everyone, I'm called Nunu Diana from South Sudan. I'm so glad to be part of this panelist during this webinar. And just to go straight to my point, with support from ITPC and Salamander Trust, we conducted a research on women's access to sexual reproductive health during COVID-19 with 5 young women living positively in Juba. However, during our interviews, the women noted that access to sexual reproductive health and HIV treatment is an issue because the treatment center is not confidential and private. This has been made worse yet due to the COVID-19 pandemic and the humanitarian crisis in the country. The treatment facility was made partly as COVID-19 treatment center, which also created fear to access of sexual reproductive health services in the hospital. And since the hospital is also it provides all other services, so there was no privacy during the COVID-19 response for people living with HIV to have freely access treatment. However, we call upon different partners and UNAIDS to ensure privacy and confidentiality is adhered during COVID-19 response and in humanitarian situation. We also urge that partners and UNAIDS should offer women and girls choice about how to access services and ensure we are not left without ARVs and contraceptives during humanitarian crisis and COVID-19 response. We also noted that UNAIDS and other partners, WHO, should consult with women and girls on more innovative ways of providing essential services that avoid breaching privacy and confidentiality. However, it should be noted with concern that issues of privacy and confidentiality are very common scenarios in humanitarian situations such as ours in South Sudan and must be taken care of to create confidence and trust in service delivery. We call upon UNAIDS regional office, other partners, to work hand in hand with in-country UNAIDS offices and us, the women organization, those who are working directly with people living with HIV to address issues of confidentiality and privacy to access of ARVs, sexual reproductive health services, both during the COVID-19 pandemic response and in humanitarian crisis. Lastly, I just want to inform all of us that since our research, we are currently working with about 15 young women and adolescent girls living with HIV to address issues of stigma, discrimination, to access to sexual reproductive health services. Thank you so much. I'm glad to be part of this discussion.
Our call to action to donors and governments is to urgently support the vital work of women and adolescent girls in their communities. Recognize and support our vital work in our communities, be flexible, allow funds to be reoriented towards more holistic responses to COVID-19. We found ourselves as women and girls in the communities that we work many times working without any funding, working without any support, but the work we do is vital and many women and girls depend on our work. We find that sometimes where there's little funding for some of our community-based organizations, the funds that were given before COVID-19 were really were really not flexible, and they were required to be used within the agreements that were made when the funds were given before COVID-19. Our call for action to donors and NGOs is to provide flexible, creative, accessible funding for women and girl-led organizations during and beyond this COVID-19 crisis. And we have women in communities, women and girls still not being included or considered in planning and consultations. We look at COVID-19, for example, when it started. Yes, it was an emergency. Yes, governments, civil society organizations, you really went into action, and also donors really went into quick action to start planning and making consultations in terms of how they responded to the crisis. But unfortunately, women and girls within their communities were not considered. Please include us in early warning systems and emergency preparedness planning, which must include affected communities. Southern Africa, for example, in recent times has been hit by cyclones and flooding and extreme weather conditions during this, as we were grappling with COVID-19. However, we still found that as the responses, sometimes emergency responses, humanitarian responses in the planning did not really meet the needs of the women because women were not included in the planning. So this is why we call on the government donors and NGOs to please include us in the early warning systems and emergency preparedness planning. And as we talk of women, we must remember that women, we are talking of women in all their diversities. This must include sex workers. This must include women who use drugs. This must include women with disabilities and must include lesbian, bisexual, transgender, and queer women. Uh, I thank you. And next slide, please.
I would like to say a sincere thank you very much to all the panelists for sharing their interventions. We've really heard a lot from the women about the experiences on the ground in the countries. Just on screen right now is just the acknowledgement of all the different people who are involved in the research and also provided contribution. Our sincere thank you to the respondents. There's a lot of information, data that was gathered during the discussion. And also just to reflect on some of the references that are available, please note we have the advocacy brief and document available on our website to share with everybody and have access to for referencing. I'll now like to invite Mr. Enias Chuma to make an intervention and remarks on behalf of UNAIDS. Mr. Chuma is currently the interim director of the UNAIDS regional support team for Eastern and Southern Africa. He's a highly experienced civil servant and economist by background and has played various roles both globally and regionally for the last 30 years. Mr. Chuma is a microeconomist by training and started off his professional career at the Reserve Bank in Zimbabwe in the 1980s. So very warm welcome to you, Mr. Chuma, and to hand over to you to share some remarks related to both the presentations by the women, but also hearing about UNAIDS' role in supporting women communities and sexual and reproductive health issues in East and Southern Africa. Thank you. Oh, you're on mute. I'm going to unmute you.
Can you hear me now?
Yes, we can.
Yes, thank you, Ame. It's good to see you again. And let me start by apologizing. It took me a while to get hooked on, but I'm glad that I am, and I did listen to interventions by the various groups, which are quite informative for me. I want to start by acknowledging, of course, the representatives of ITPC, Salamander Trust and Making Waves, and also my colleagues from the United Nations and all other panelists and representatives of civil society. And thank you, ITPC and Salamander Trust, for extending the invitation to UNAIDS East and Southern Africa to make the opening remarks at this important webinar. The webinar comes at a critical moment when the world at large and the ESSA region in particular are grappling with the second wave of the COVID-19 pandemic. The research commissioned by ITPC and Salamander Trust focusing on our region is particularly important given the context of COVID, the history of HIV in the region, and the vulnerability of adolescent girls, in young women, and women in general in the region. East and Southern Africa, as you all know, is the region most affected by HIV in the entire world. East and Southern Africa is home to around 6.2% of the world's population, but over half, 54% of the total number of people living with HIV in the world are in this region. Although the HIV epidemic in East and Southern Africa is generalized, young women, men who have sex with men, transgender people, sex workers, prisoners, and people who inject drugs are at an increased vulnerability to infection. Our UNAIDS East and Southern Africa Epidemic Overview of 2019 indicates that of the 20.7 million people living with HIV in the region, 59% are women aged 15 years and older. Women of this age group account for 54.8% of all new infections. In this context, gender inequality remains one of the key drivers of the epidemic among women globally, and particularly in our region. Unequal power relations, unequal access to opportunities, including education, employment, and many other factors, including culture and traditional practices, leave women vulnerable to HIV infection and unable to access life-saving treatment when they need it. Thousands of women across the region are unable to make critical everyday decisions that often mean the difference between preventing and contracting HIV. For many women, including adolescent girls and young women, the decision to access ART and general health care, including sexual reproductive health services, is also beyond their immediate control. Before COVID hit in 2019, we collectively made strides to address the inequality gap, resulting in positive changes in women's access to treatment and small gains in reducing new infections among women and other key populations. Actually, COVID hit in 2020, just small change there. Today, COVID-19 has deepened the inequality gap. The pandemic is threatening the progress made and, in some cases, reversing the gains. The rise of gender-based violence has left women and girls much more vulnerable and at risk of sexually transmitted infections, HIV and AIDS, and unwanted pregnancies, much more than ever before. In the area of health, changes in the delivery of healthcare and the deprioritization of essential services as governments grapple with the delivery of COVID care has left women unable to access contraceptives and many other essential health products and services. In this context, many women and girls are vulnerable and unable to make sexual and reproductive health choices. The redistribution of funds as donors and governments shift resources to the COVID-19 response have also left health systems, women's organizations, and organizations working on HIV without resources to do their work and deliver much needed services to women. Community-based organizations, which have proved to be central in the HIV response are largely unable to play their critical role in community mobilization, monitoring, and supporting community women's groups in the fight against HIV and AIDS. The current context, therefore, demands an urgent shift in the way we address concerns around women's rights, gender inequalities, and how we craft our HIV response. A much more nuanced focus on vulnerable populations whose vulnerability is exacerbated by COVID-19 is critically required. Stakeholders must adapt their ways of working to ensure that all responses are crafted to deliver relevant critical services and to support women and other vulnerable groups in this moment of uncertainty, fragility, and rapid change. Knowledge generation is one of the critical steps towards nuancing our response to ensure we rise to the demands of the present moment. There is therefore a need to create knowledge and gather evidence on how COVID has impacted women, girls, and other vulnerable groups within communities and countries across the region to ensure that the HIV, COVID, and all responses mounted match the context and lived realities of all people, and in particular, women living with HIV and AIDS. Any credible information, knowledge, and data should be shared widely to enhance the rhythm of collaboration among different players in the field. The UNAIDS ESSA office commends Salamander Trust and ITPC for not only undertaking the research on the impact of COVID on women and girls living with HIV and AIDS, but for going a step further to share the findings. We're all tasked with the responsibility to reflect and act on the findings, which are focused on key strategic areas, including access to sexual and reproductive health and HIV services for women, the digital divide. Digital communication tends to leave out many women and girls, funding for organizations led by women and girls living with and affected by women. And I noticed that this point was made by an earlier speaker. I think it was particularly important going forward. In closing, I want to extend my congratulations to the organizations which championed this very timely and important research. As we fight this pandemic, I wish to call upon all of us to put these findings to good use. And I want to thank you very much, and I look forward to the outcomes of this webinar. And I also want to take this moment to inform those gathered that at UNAIDS in my office, we have now a senior gender advisor, Cynthia Lungu, and I'm sure you've seen her, she is participating. And I look forward and encourage you to work very closely with yourselves to share information, to learn, and to strengthen our collective response to the challenges that we face. So let me stop here and thank you very much, and prepared to learn and listen as we go forward, although I may have to leave within the next hour or so. I thank you very much indeed.
Thank you very much, Mr. Chuma, for those remarks and the commitment of UNAIDS to really address some of the critical findings that have been highlighted, both in the study, but also as advocacy asked by the women. I want to say, invite now the question and answer discussion session, and to invite the panelists, the women themselves who spoke and make very strong, clear deliberations around some of the issues that we're seeing on the ground in terms of the access barriers. And just to really highlight that some of the findings are not just specific to service delivery and health facilities, but also livelihoods of women, the gender-based violence issues, stigma discrimination issues, and looking at it, young women to all categories of women in the community. So this really is a lot of rich feedback, and just opening it up for now, question and answer discussion. Can I invite Joyce, Martha, Omar, Jacqueline, and Diana to join me? And we'll just take some of the questions that are in the Q&A for the next 15 minutes and respond to. So panelists, if you can actually just share, there's a few questions that are in the Q&A box, and thank you very much for everyone who's posted. One question from Talim, how are you addressing issues of mental health with women living with HIV during the pandemic? I think that's something that we've seen quite a bit. If I can invite Joyce to maybe start us off, and then other panelists to contribute.
Thank you very much, Wami, for the invite and for the question. I'm just going to attempt to answer this, that at a personal level and at the grassroots level, we have been trying to address issues of mental health by having online forms of support groups and just having personal connections between women. And you find that there are many WhatsApp groups that have come up during this period, and other social media avenues that do not necessarily require a lot of, but just call to action as mentioned that there was no much funding for such implementations or for such activities, because there is no way we could quantify or we could meet the donor expectations on how to quantify the quality or the number of women who have been reached with mental health messaging, and how effective that program has actually been. So just like during the presentation, just like we mentioned, that this is majorly some of the work that is done by women, and our passion has been supporting us through this. So yes, we have been trying to do some work at personal levels and at different organizational levels, but I would not say it has been implemented in large scale due to lack of resources. Thank you.
Thank you very much. Would any of the other panelists like to also comment on this? Maybe I can call on Martha.
Thank you, Wame. I think, like Joyce said, we have used what is available to us has been the phones, and also some people staying in the same neighborhood, trying to make sure that someone where they are staying, they have someone who is close by, and make sure they are connected. We know it's difficult to have the physical or face-to-face contact, but sometimes it has to happen because a lot of women are living hand to mouth. Our governments have not, while they have imposed lockdowns, a lot of them have not made sure that that the women's livelihoods are actually taken care of. What do they eat? So for those who have been depending on looking for money each day and for the meal for that day, they need to go out. So women are supporting each other. We use WhatsApp. We also use SMS. It's really difficult. It's really difficult, even as for those who are coordinating as well, who try to coordinate. It's really difficult, but in many ways, you just try to keep that connection. And we need a lot more support, because for a lot of the women, while they may want to be on WhatsApp groups, who do not have the gadgets. Some may have enabled smartphones. Maybe it's a smartphone that was a hand-me down that is now very old and cannot support some of the functions. For example, one of the women who contributed extensively to this to the research by giving was a key informant. Because of her phone could not log into the webinar, neither could she log into Facebook. Even though we tried to make sure that she has some data, but then it's because of the gadget itself. So it's a multitude of layers of barriers that women are facing, and that also compounds the mental health issues of women, the mental state of women. So we really need to have this, like Joyce was saying, in terms of quantifying. How do you quantify that someone, how much impact has been done in terms of making sure that women's mental health is really taken care of, and mental wellness is achieved? I think it's very difficult, but it's a need that is there, and it's very long term to get the results. So we really need to find ways to say a person's life is not like a light switch that you can just switch on and off. For a person to function, we need to make sure that we need to look at them as a human being and not a machine. Thank you.
Thank you very much for that, Martha. There are two questions that have been raised, and it's been raised to UNAIDS around one, what is the statistics of unwanted, what are the statistics of unwanted pregnancies, particularly with sex workers during the pandemic? And linked to that is really around whether there's any knowledge or evidence of sexual violence in school-going girls who become pregnant. What is the re-entry intervention that UNAIDS can support in Southern and Eastern Africa? So Chris or Mr. Chuma, is there any thoughts or feedback on that?
And also Cynthia is here, and I'm sure she will have some great insight. I'd just like to go back a little bit on the mental health, and it's hard to follow Martha. It's basically, I agree with her, it's about seeing us as humans, we're not machines. And it is about recognizing that mental health is an important part of our health. And therefore there are ways to measure it, and there are ways to address it. But there's also ways to remove what puts our mental health at risk. And address that. Violence, the way our women are treated by their partners, by the communities in their work for millennia, to services that address their mental health after they experience violence or any other form of injustice. So it is a complex issue because it is about humanity and we are complex. But there are ways we're addressing it that is about that come naturally when we think of us as humans and not machines. So thank you, Martha. I don't know the statistics, and so I need to come back to my colleagues to get statistics. But one of the things that struck me throughout the last year, and it's not just COVID as an epidemic, it's actually more the response to COVID. It's the same. What we see, the experiences of girls and women are manifestations of the same gender inequalities and injustices forever. And they're just only amplified. So the question is, what do we do in a situation of crisis that we haven't done and we should have been doing in the absence of crisis? And so I don't know. I don't want to go too further into the interventions because Cynthia would probably have a better answer to give you. But for me, it's that struggle that I have the last year in terms of, but why shouldn't we have been doing this before? Why, what it is, and and because we haven't addressed some of these deeply rooted social, structural, religious, economic norms that drive the way that we've designed the law, we've designed the social relief programs that leave sex workers out, and so on. So it's I don't really have a very good answer other than we do more of what we should have been doing before. But of course there are responses for crisis. But Cynthia, I don't know, I don't want to put words in your mouth and therefore.
Yeah, thank you very much, Chris, for coming in. But just to say, anecdotal evidence obviously is pointing to a spike in the rise of teenage pregnancy across the region. I think earlier on, the regional director referred to the critical importance of knowledge as we live within the COVID pandemic. And so we continue to generate information, to collect information and evidence to understand the extent to which, the extent of the teenage pregnancies and the rise of that given the pandemic. In terms of what we do, referring now to the issue of getting the girls and young women back into school, as Chris has said, what is it it that we haven't been doing in the past, or what is it that we need to intensify to ensure that we address the challenge? And so you can look at several spectrum. There's the spectrum of policy. There are certain countries in the region that do not have the relevant policies to allow the readmission of girls back into school, obviously. So that is something that we would like to advocate for at UNAIDS. And also, we tend to have a lot of policies on paper, and those policies are not implemented. So the other question is also around how do we ensure that the policies that are put in place are actually effectively implemented to ensure that the girls actually make it back into school. And if you look at the issue of teenage pregnancies and getting girls back into school, it's more than just beyond getting the girls back into school. You have to look at issues of the support system and social protection. If the girl is going back to school, who does he leave the child with at home? So we need to consider all those spectrums before we actually craft an ideal response to what we are going through at the moment. And obviously, there are certain countries that already have in place the policies and they got in place the back to school programs. And at UNAIDS, I think we're happy to work with organizations, the UNAIDS country offices in those countries and other stakeholders that are working on those back to school programs. I won't address the issue of the sex workers because I think Chris has addressed that. Thank you.
Thank you very much, Cynthia. Meg, can I hand it over to you to share some thoughts around the WHO and mental health programs as well?
Yeah, thank you very much. And I have to mention also that I'm double tasking some meetings, so I'm going to make a bit of intervention around mental health. I have to join another meeting and come back, but I've been listening so intently and really want to thank what's coming up. And I think mental health has been a topic that has been on the Director General's mind. And if you follow any of the conversations around COVID that are happening, mental health has now been fully integrated into the emergency response plan. And there's also a plan for handling the mental health also of all the healthcare workers and others. So there's a recognition that it's really a challenge across the board. Just this week, we had an executive board meeting for WHO, and there we actually were able to, there was a plan that was accepted by the board to introduce mental health training, planning, reaction actions for COVID into the emergency response actions. So with that, I just wanted to make sure that you were aware that this is high on the DG's list. There are lots of materials that are found on our website, and we would be happy to sort of link those into anybody who would like to find them, including stress reduction that could be used at the community level, could be used by anyone to handle some of those immediate challenges that we all face. So thank you.
Thank you very much. I'll now like to thank you very much to all the speakers and also to the questions and answers. There's a lot of comments, really great feedback from the participants. Please take the time to also read some of the Q&A. We won't be able to get through all the questions today, but we'll make sure that we have a Q&A information that we can distribute after the webinar. So thank you very much to the panelists, the women. Thank you very much for the contribution and to UNAIDS as well. And I would like to introduce and hand over the next session to my executive director, Ms. Solange Baptiste, and she is with ITPC based in Johannesburg. Over to you, Solange.
Thank you very much, Wame. What an exciting webinar. Really great to hear all the presentations. This segment of the agenda is really to dig a little deeper now with our development partners and friends. We have the WHO and UNAIDS colleagues on this call, and they have been already speaking up. So it's more like a continuation of the conversation. And we want to really explore, what can development partners do to better support women and communities of women living with HIV in this current COVID context. What we've heard so far is clearly that we knew that we had problems. It was a bad situation and things have gotten extremely worse. And so we want to explore the co-creation of some solutions. We want to think about some advocacy, really priorities and any suggestions that we have. Unfortunately, most of the issues that have been raised today are not going to be solved by clinical interventions. They are not going to be solved by the health sector alone. And we need to think about other sectors and obviously a multi-sectoral approach. So I would like to not talk long and let you guys actually hear what interventions will be made by UNAIDS and WHO. I'm doing it in that order. I think it still works for Meg and Andy. So we'll start with UNAIDS, really thinking about how to shift the political will to ensure that the issues that have been raised and the rights of women living with HIV are funded. And what can WHO and UNAIDS, well, starting with UNAIDS, what can UNAIDS do to better support communities at the local level? And I want to make a plea for that, right? At the local level, at the not just the national level. So local level, national level, regional and global levels. Perhaps we can start with Cynthia, and I don't know, Cynthia, if you were introduced formally, but Cynthia is a gender advisor for East and Southern Africa at UNAIDS. So over to you, if you could just make a few comments from your lens, and then I think you're sharing your time with Chris. So about 5 minutes, and then 5 minutes with Chris. I'll introduce him when you're finished, and then we'll move to WHO. Thanks, Cynthia.
Yeah, thank you very much, Solange. And I like the fact that the focus should really be around what we can do at the local level. And I'm quite glad that my colleague Chris, who leads our work around community support, is in this session, and he will shed more light on that. I think maybe we've all agreed, that with the COVID-19 pandemic, we've seen that it has further enhanced all forms of inequality, and particularly gender inequality. Once COVID-19 hit, we saw a rapid increase in gender-based violence, which was then dubbed as the shadow pandemic. We saw the deprioritization of service as health systems overwhelmed began to triage services. We saw critical SRHR services were deprioritized, depriving millions of women choice, as has already been articulated here. I think in response, what UNAIDS has done is to continue to work with governments, policymakers, and COVID-19 response teams to ensure that critical sexual reproductive health rights services remain available, even as healthcare systems make room for the COVID-19 response. And here we particularly focused on ensuring that countries domesticate the regional SRHR strategy developed at the regional level. We also tried to influence the inclusion of gender and HIV in the development and implementation of COVID-19 strategies. We saw, that the singular focus on, COVID-19 strategies within the health facility left out a lot of the HIV work and critical SRHR services. And so we sort of influenced the inclusion of those two in the development and implementation of COVID-19 strategies. We continue to ensure that our programs remain cognizant of the linkages between COVID-19, gender, and HIV by, among other things, we've sort of done a continuous generation of knowledge. We continue to collect information because the current environment is dynamic and quickly changes. So we feel that every information and evidence collected is vital to inform the strategy and our response in the fields. We also advocate and continue to support the collection of gender disaggregated data to ensure that we do not leave out women and key populations that are important to us. We've also supported and empowered regional and national networks, groupings of women living with HIV, to sort of occupy spaces in decision-making forums to push for the women living with HIV and AIDS agenda. And here, when I say we've sort of empower different groupings, it's important to clarify or to highlight that for us, gender is not just about, you know, women and men. There's all the other groups, transgender groups, and all that was referred to already by one of the speakers. And I quite like the fact that one of the speakers highlighted that point. It is a very important point. It is very critical. It's gender is not a binary concept. We need to normalize that kind of thinking, and we need to be thinking of all the other groups that are oftentimes left out. As I said earlier on, I'm quite glad that Chris is here to sort of narrow and zero down into the nuances of the community support work that is being done at local level, or our thinking, our strategic thinking in that line. So over to you, Chris. Thank you.
Thanks. Yeah, and I don't think I can describe all of that in 5 minutes, but perhaps what I can try and describe is not what new we are doing, but rather what we are trying to change in terms of how we do things. And I think it applies to many of us. So it really is about changing the narrative, I guess. Starting from a homogeneous group of describing women and men to address gender equality, to unapologetically describing a diverse group. We are all complex in our humanity, and it's about going into this without any form of restriction. It's really just always address it in diversity. It is about changing the way we design programs, and the response, I think, as well to COVID, in that not to design response that reaches the general public, but those most left behind. If we design such a program, it will also reach those that are easily to reach. So think about the sex worker who is not going to be able to access the social relief grants because of they're criminalized and they are socially excluded. If we have them in mind and their participation, I think we would make wonders. We need to approach it in a longer term response to gender equality, as well as that crisis, and the two have to come together. So in all of our work, and so right now we're focusing a lot on supporting communities to drive evidence and convert that to evidence from advocacy. Not that sounds lofty, but it's actually small actions can do that. And it's disrupting by not focusing at the policy level, but it really is about how do people access services. And by that, not just at the clinic, but their journey to the clinic, their life at home. If they are able to access employment, what happens at work? And looking at the holistic needs of people and how all of those factors enter into accessing services and their ability to live quality lives of dignity. So we've been working with most left behind populations, many key populations across, to find and to work so that the work is coherent, so that at the end, there is a mushroom of shadow reports that will be coming that are at the local level, and that they can be used to, because we do not divide HIV from SRHR to UHC to access to health or rights. It's all about all of that at the end does have an impact on our health, on our ability to access services, on our ability to respond to COVID. So we are working with networks to design something that's simple, but can be used across platforms and can address the complexity of us as humans. But there's one area I think that we want to explore further and with all of you. And while we do all of that, which is about services, policies, the movement to research it and be able to do its work, the work on data, strategic information, we also need to work on social norms and changing social norms. Because at the end, who writes the policies, who writes the laws, who delivers the services, who teaches at school, and how are we all influenced by what we've learned at home throughout our lives? So we need to do that harder work of changing social norms. That we'll start a bit of an experimentation later this year, and whoever wants to join us, please do. And let's start, I think, to start questioning that, because if we don't, gender-based violence will continue. Girls will not access education forever. And I think gender inequality has gone way too far and for way too long. So it's about supporting networks to be leading in knowing and be able to translate what the people, their peers are experiencing, and be able to use it at policy level and at community level. But that experimentation at the end that we'd like to work with you on, how do we change minds and hearts? Thank you.
Thank you, Chris. Lots to think through there, right? I mean, depending on the day you ask me, I could be in a state of we will change the world, or I could be in like complete paralysis, or I could be like ready to buy a car. It depends. So there's a lot. I mean, you need to change the norms, you need to fix the policies, you need to enforce the policies, you need to get the right, the choice, the informed choice when you're actually making that decision. I mean, it ranges the gamut. And so we're trying to kind of figure out then how do we prioritize, and what, as you said, and Cynthia alluded to as well, the local or also the short, medium and longer term goals that we need to work on together. I really wanted to go back a little bit to, before inviting Andy to make his intervention, to Joyce's slide where she had the sharks in the water with the boat, and really kind of come back to our extreme biomedical, clinical entry points. I want to place it that way, into what these interventions are, while paying sometimes more lip service to the structural, legal, and other kinds of barriers that are the true sort of almost root causes of these things that we're putting Band-Aids on, right? So yeah, I can get you the best medicine, dolutegravir based, great, but you still can't eat. You still are a victim of violence. You are still being taken advantage of by the police. You still experience so many wrong things, which is why I was going back to the fact that this has to be a multi-sectoral thing. Many of the questions and comments coming back here talking about unpaid leave, that means you're talking about unpaid work. So we're talking not only about donors and relaxing their restrictions, but economics, transportation, security, what would the police, the military, do they know about disclosure, and are they passing around the information and calling who and who by what name? Social services, education and schooling in the time of COVID, and the digital divide, the issues are enormous. So I just wanted to kind of place take off our typical biomedical lens as I move seamlessly to the WHO for the intervention, and hear what Andy thinks about these issues that have been raised by the ladies in the first hour.
Hi, Solange. Thank you so much, and good afternoon to everybody on the call. Apologies for not being able to use my video. Bizarrely, I'm working from the office today, and we have more technical challenges in the office than we do when we're working from home. And Solange, let me start by just saying, fantastic work. So congratulations to all of the presenters and all of the women who have contributed to the research that was presented earlier on in the webinar. It's this kind of information sharing, first of all, that I think is critical to all of the challenges that we face in terms of really, doing our best to unite the various services that need to unite, and the various sectors and parts of government in order to meet the needs of communities, which as we've discussed today, have really been exacerbated under the COVID environment. So let me say a few things from the perspective of WHO. I think first of all, we've got some interesting examples of where we have helped to create the kind of enabling environment that hopefully would allow for greater community participation and action, including from Eastern and Southern Africa. We work closely with communities quite recently in Tanzania to support a shifting in the age of consent for HIV testing from 18 to 15, to really free up some space for adolescents, including, of course, young women, to be able to access some of the critical services that they need. And that was really a partnership effort. UNAIDS was involved, UNICEF was involved, as well as communities. And I think it's that kind of partnership that really is critical, particularly for the WHO role. We really value the partnership with Chris and the UNAIDS team. We often come in with the technical expertise, with perhaps a different kind of influence with government and with ministries of health, but we don't necessarily have the dedicated resources around community development and support that our colleagues in UNAIDS have. So that partnership is important. And I think, again, when we look at Tedros is really keen to strengthen our in-country capacity to be better partners with community and with civil society, and to work with government to create more space for some of those critical conversations. But while that's happening, there's an awful lot going on in any case. Many of you on this call were involved in creating the consolidated guidelines focused on the sexual and reproductive health and rights of women living with HIV. This is still an important tool that has community-led operational guidance developed on the back of that still remains relevant, and we can do more, certainly through our country offices, to ensure that the tool is understood, is known, and that our counterparts in ministries are aware of it and respond to it in the spirit of that tool. Similarly, when we look at how we work within that family of UN agencies, particularly from a country level, we're often quite central to some of the conversations around direction of some of the bigger funding buckets that come from Global Fund and PEPFAR. So we can create the space for some of that funding to flow. We're not, so we are sometimes a little bit a step away from some of the things that you've seen mentioned in the chat, but that would perhaps involve a bit more of a hands-on leveraging of funds that can get to communities, including those that aren't officially registered, because they are very much grassroots organizations that don't have that core secretariat capacity, if you will, to engage perhaps more formally in some of those larger funding opportunities. But nevertheless, we can work with those partners, with Global Fund, with PEPFAR, to make sure that the language, the themes, the priorities that are important to women and young girls are certainly prioritized. And many of the issues that we've heard about today, including recognition of women in their diversity, female drug users, women from LGBTQ communities, we can take forward the spirit of how, as well as the what, in many of those conversations. I think the other area of work that WHO is focused on, that's not necessarily specific to either HIV or sexual and reproductive health, is really around the huge push underway in-house to encourage more inclusive governance for health, and particularly in terms of the COVID response, and building stronger, forward-looking, more resilient systems in the future as we continue to move through the COVID epidemic. We've been doing quite a lot of research around what does inclusive governance look like around COVID in countries. And as you may suspect, when we look at the gender dynamics and the power dynamics of some of that decision making, women are not at the table. Female voices are not being heard in COVID decision making in countries. And one of the things that we do to encourage that is to periodically monitor the situation and report back and out on that, so that hopefully we see some reactions to that and improvements. So we're certainly trying to take a gender lens and a power lens to decision making in countries, and from both a universal health coverage, primary health care, and a COVID perspective. And I think my final point would be, again, as we continue to evolve as an organization, You know, our emphases will continue to be on people-centered approaches and trying to evolve as an organization to respond to what we hear from communities, but also to continue to look at what can be really set in place through a primary healthcare approach and framework. And that's where we see the critical interface between communities and primary care. And there's a huge blurring of responsibilities, of personnel, of issues when we look at both the needs and the services and the challenges that countries face. And so we continue to really look at primary healthcare and community, that community interface. And several of you are also engaged in our advisory group of Women Living with HIV, which I think met twice last year and really offered us some timely advice around the COVID situation. We've recently had some critical questions posed to us as well to look at around people living with HIV and vaccines for COVID, which we're working hard to address within the coming weeks. So there'll be more from us soon on that particular issue. So once again, trying to create the mechanisms that respond to the local, but perhaps are a bit more global, like the advisory group, but making sure that we try and provide the information that's critical, that we're access to and helping create at the global level, regional level, and even at country level, into information that's palatable, usable, and appreciated and understood by communities who at the end of the day are critical amplifiers for the work that we do, and also critical informants for the priorities that we need to focus on. So let me pause there. Solange, thank you so much for the opportunity. I think Meg will be joining us later again, hopefully before the end of this session. So we might have an opportunity to invite her to also make a few concluding remarks if we have time. Thanks.
Thanks very much, Andy. Very thought-provoking things coming from both UNAIDS and WHO. I want to open up now for a bit more of a free flow discussion. So I don't know if any of the ladies on the previous panel would like to make an intervention or ask a specific question. If so, please either chat to us on the side on the panelist or raise your hand. And I'll be sure to give you that space because we have a little chunk of time left for discussion. Okay, Martha is already ready. It's perfect. Martha?
Thank you so much. Thank you to... Hello, can you hear me now?
Perfectly,
hello?
Yes.
Hello, can you hear me? Yeah,
yes,
okay. Thank you very much, Solange. Thank you to UNAIDS, Chris, and okay.
Cynthia.
Sorry about the names. I'm growing old. Cynthia, yes. And thank you, Meg and Andy. So anyway, I think the most frustrating thing for me as a woman living with HIV has been around the lessons that we had from dealing with HIV, which we are not taking up as we deal with COVID and as we deal with other issues that are upcoming, that are emerging as our physical health stabilizes on ARVs. The issue is that as women and girls, we are doing what we have always done. We did it with HIV, where we organized ourselves within the communities that we live in. We organized ourselves to take care of each other, to make sure that we look out for each other. But then when the disruption that came should not have come to disrupt the way we live, when funding came, the disruption should have been on the funding side to change their way of doing things and fit in with what we are doing. What I find a lot of times is that governments, NGOs, donors fit into what is easiest for them, what is convenient for them. but is it convenient for us as women living in the communities, as girls and adolescents in the communities? Is it does it fit our way of life? It's actually disrupting in the way that we now have a lot of catfights around who gets to which table with whom, who is holding the money, who is holding which one is holding the money, and I need to elbow this one out, because this is what this is the system which should have. This is why we were saying in the planning and for anything we should be involved. So if it comes already as a pre-arranged package where we have not been involved, then it causes all this disruption in the communities, in the way grassroots organizing is carried out. And we've seen, and when that happens, then it still causes a headache for the NGOs, for the donors, for government. And also then the other thing is around making a group of women who live in the community and are supporting each other, to say a requirement for you to get any support from us, from government, from an NGO, from a donor, is that you need to be registered. For me, living with HIV, I mean, can you please register my being an HIV, having no HIV? Because then that would make me not be a headache for anyone. And I go about my way. Sorry to put it in such crude terms, but I think, as Chris was saying, we need to disrupt, and I'm trying to disrupt in the way I'm also responding to UNAIDS and WHO to say this. I think there's need for a complete shift. So we need to restore the trust, because trust is fast disappearing for people living with HIV. Women living with HIV, adolescents, girls. Trust is fast disappearing in trusting NGOs, in trusting the donors, in trusting. But in many ways, we need that support. We are working without any support, unpaid care work. Anyone who is no longer, when a hospital is no longer able to take care of anyone, they are sent to a woman to look after them in the community without any resources whatsoever. You still need to go to the well to fetch some water to make sure you are caring for this person. And it's made worse by this COVID, where you need more water, and also the messaging around COVID is very elitist, which is talking about you need to wash your hands for 20 seconds with running water. Even in urban areas now, in a lot of urban areas in Zimbabwe, running water has disappeared. And and you need to, how much water can you store in your one room to make sure that you and your 3 children or 4 children who are living in that one room are able to sanitize properly and make sure so I mean there's a so my call is just to say, let's disrupt and meet the women and communities where they are and meet their needs. What works for them, not what is easy for governments, for the UNAIDS, for the WHOs, for the government, but also to say what will work for the communities. Thank you.
Thanks very much, Martha. Chris, Nunu wants to speak, so maybe I'll just ask her to speak first, and then you can come in.
Yeah, I just have a concern for UNAIDS because in-country UNAIDS has failed in organizing and reorganizing different partners and grassroots actors working towards women and girls living with HIV. And that has actually made it very difficult during disasters such as the COVID-19 pandemic in terms of how information can be channeled to such group of women, and how do they get information about COVID-19. For instance, in South Sudan, there was an inaccurate information about COVID-19 and its impact on people living with HIV. And we couldn't see UNAID like coming up to make sure that there are forums organized for these women, or even if these are forums, online forums, and maybe, trying to reorganize organizations and civil society working towards young people or women living with HIV positively, to make sure that information is channeled to these women right from the national level to the grassroots level. And then on the issue of the issue raised on mental health earlier on, I think that would actually be one of the major things that UNH would have taken into consideration since the beginning and the outbreak of COVID-19 all over the world. Because much as we all know, somebody who is living with HIV is already living a traumatic situation, and it's already self-stigmatizing herself. So basically, UNH would have come up with different forums inside the country or regionally to make sure that we convene such webinars to make sure that information is accurately channeled to women living with HIV positivity. So I think that is one of the challenges that we are facing with UNAIDS. I just also want to applaud them for they are supporting us, a very small group of young women and adolescent girls in our community, in our community forums, but they are not doing much because that is a seed funding. I also encourage like UNAIDS to be giving us a huge amount of money. They should move out of giving us $5,000 maybe to a huge funding that can, can bring many people on board, and information can be channeled to, more than 50 people within the country, not only the seed funding. Thank you.
Thanks very much. Chris, would you like to say something in response, and then I'll go to you, Jackie?
Yes. First, I think I wanted, because Martha said something I think is really, really important, and this is where we all need to act. The UNH needs to take a strong voice and be stronger, but we also need a community that is stronger and can shout. When it comes to designing social distancing measures that a family of 10 in 2 rooms cannot put in place, we need to speak up. We need to raise our voices. When the response to schooling for children, return to school, is about ensuring that, coming up with a guide on how to ensure a school is safe for students to return, we need to ask ourselves, can a country do that in a year for all schools? And not describe the home only as a learning environment when we don't have basic tools for the children to be able to continue learning at home in a situation like that. And so we need to also question the relief programs that go out there that are about ensuring that at the macro level, the country is able to be economically viable, as opposed to perhaps disrupting at the micro level and providing some support to. So I think we all need to reflect in terms of what have we learned the last 20 years? And now we have vaccines, and we have the same issues of a delayed response and a delayed delivery to a region because of certain intellectual property processes and economic processes. So it's that, I think we need a disruption in terms of going back, and yeah, we made mistakes before, but there are things we can learn from. And we, of course, as UNH, we need to be stronger in terms of calling for resourcing for communities. But we don't have the resources. But it's not, that doesn't absolve us from the responsibility of taking a stronger role. Now we have the opportunity of a new global aid strategy. And in that global aid strategy, there is a position for communities that is of a higher, I think, level acknowledged to be. I think it should be higher, even higher. But it does put at the center that, and acknowledges and puts it in terms of actions and strategic priorities of that need to have communities be partners, be resourced, be heard, and be able to make decisions at the national level. So we have an opportunity, but call us on it when longer in terms of voicing, but we all need to do that collectively. And it really pains me to see the same mistakes again and again, and communities are.
Thanks very much, Chris. I'm going to put on my advocacy hat and start asking very pointed and specific questions in a minute, especially since Meg is back. Jackie, did you want to say something?
Yeah, I'm going to hope you can all hear me because of the connection issues in Uganda. So I just want to really thank UNAIDS and WHO for the points that they have made. However, with the reality that is happening right now, for example, the technology issues, as we are also thinking on the programs, that are going to benefit the women living with HIV, or the women with disability, or the women in specific, let's think about also, supporting. Oh, I would like actually to really request that let's think about projects that encourage technology, because right now, for example, we would love very many women to join the call, but unfortunately, even when we knew that some of them didn't even have smartphones, we expected some of them we had to give. Like, for example, I had to give one of my phones, one of them, to join using my personal link, so that they don't miss out the points that are being raised. So it is something that, as we are also thinking on how to support the women, let's also see how do we empower grassroots organizations in technology, as the trend is now moving in that direction. The other point I would want us to really emphasize on in terms of support, grassroots wise, is the mentorship. We know that, as COVID came in, we are really losing a lot of wonderful mentors on ground. So I would want us to still think that, having the mentorship programs at a grassroots level, supporting grassroots organizations for mentorship programs would be something that, let us not, leave it out of the context, now that we are addressing issues that, are being confining us in this era in time. So mentorship and technology are some of the points that I wanted to raise. And if anyone would really add on that, I would be grateful. But I just wanted to add in regard to what I mentioned earlier in my presentation. Thank you very much.
Thank you very much, Jackie. That was very, very insightful. And if anyone wants to add, what we have, we'll do a round of questions now with UNAIDS and WHO on some specific things that have come up. And then I think we have one person that has their hand up, and maybe we'll allow them to speak. So let me just get to some other questions. So look, the WHO will say, and you have said, we come in with technical expertise, we're not super well funded, we do what we can, and we're doing our best. I think UNAIDS is also saying the same thing. We might have a little wider range on the political flex, right? Because we can convene. We might have some resources for community development and coordination and support. But we are also constrained by member states and what the funding resources we have to be able to address some of these issues. So I want to understand from your perspective, while we already all acknowledge the limitations within which you work and live, how can we address the specific issues that have arisen here? So for example, is there anything that is preventing the WHO or UNAIDS from producing specific guidance documents, right, on women and girls living with HIV, I guess, across the lifespan for COVID? Right, what we have at this present moment is bits and pieces in different clinical guidelines. And if you have a baby, maybe that would work out for you because it's all about breastfeeding women and pregnant women. But if you are just a woman, maybe you are not really seen. And maybe we can just pause there and see, is there a reason why UNAIDS and WHO are not able to produce specific guidance documents on that?
So this is Meg, so maybe is it okay if I jump in right away and just give you a sense of, you know, from what we can do and where we need to maybe change some of our approaches and advocate for different ways of doing it within WHO as we move forward. I want to say, you know, the conversation here is really so in depth, and it's really hard to hear some of these issues. And of course, yeah, I'm trying to keep up with all the questions and the comments, but they're very important. And so I want to thank you for pulling this together and sharing and bringing that information to all of us. In the beginning of COVID, at least for especially sitting in WHO, there was definitely a need for across the board guidance for all populations. And there was a desire to have every guidance that would come out that could be utilized in whatever setting and not specific to a certain population or to specific disease entity, but to really look at the cross-cutting nature of COVID that is affecting every person, and being very being very much centered around that. So it was challenging for us to say, centrally, could we put together a set of documents or guidance just for the HIV setting, because you've got all of those persons who are living with NCDs, who are also at higher risk. You've got a number of people who have tuberculosis who are at risk, malaria who are at risk, ANC is at risk. And that's when there was sort of a centralized approach developed at WHO for putting out guidance around what to do to maintain essential health services, how to think about restarting essential health services. And with that, and we embedded some of the unique specificities around HIV and hepatitis and STIs and TB, et cetera. And those, if you haven't seen them, I mean, if you go to our WHO website and for guidance, it's overwhelming. There's probably 400 different pieces of guidance there to wade through, but it's under maintaining essential health services. And there you'll see a number of documents, one that was called the Pulse Survey that has been now done twice to do an evaluation across all 194 countries around the world. What are the main services that are being impacted? And what you could see is from COVID, the kinds of services were outreach, and primary care. And I don't think there was a specific comment around, peer support at all, because I think HIV is quite unique in that we have this whole differentiated models of care working in the community. It's very well developed, whereas may not be as well developed or is under the topic of outreach and many other disease processes. But you'll see guidance there. And it may not be enough, is what I can see from what I'm hearing. There's guidance on how to open up again, how to maintain services, and actually what are which services are most readily affected by COVID. Then there was a number of things that we worked on collaboratively with UNAIDS to take a look at some of the GAM data to say, where are we actually having the most impact from COVID? Is it testing? Is it treatment? Is it initiation of ARV? Is it ANC? Is it key population services, prevention services? And what we'll see from that, if you've looked at those documents and data pieces that have come out, is the services people have done incredibly well. And I think the kudos go to community-based services that have been able to maintain people who are on our ARVs. That was by and far thought to be the most important thing to do during this time, make sure people had access to their ARVs. But new testing, prevention measures, making sure that ANC is working, EMTCT, starting new people on treatment, community-based services have fallen off the wayside. And I think that has been documented in many of our studies, but what we're starting to see also is that it came back when the lockdowns were opened up, but I'm sure, in this second more serious wave around the world, they will be seriously affected again. So is there anything blocking us from looking across that why kind of guidance we've been asked to do that's not disease specific, and building something that's much more disease specific around women living with HIV? I don't think there's anything stopping us from doing it now, because I think the context early on was we can't confuse people with too many guidances. You know, we have to get the basics out there. We have to ensure that people know what treatments to use. Is it steroids? Is it, you know, is that good or bad? Is hydroxychloroquine good or bad? I think we have enough of that basics on treatment, infection prevention, you know, that it's clearly important to keep nutritional services going. It's clearly important to keep our vaccination programs moving. It's clearly important that women can deliver in a safe setting. It's clearly important that that we need gender-based violence programs because it was exacerbated during lockdown. All of this, I think, is now well known, and it's sort of a timing issue. So I think going forward, I don't see that there would be anything stopping us at WHO to working on that. Except for, you know, like everyone, you know, the time of the day. And I think it would be, this kind of guidance would be best done in a collaborative way, bringing partners around the table and pulling upon our recommendations that we have already, and seeing how we can pull that together to be much more responsive to the needs of women and girls living with HIV. It's a bit long-winded, but I agree with you that we've put out bits and pieces a bit more reactive, and that initially for us at WHO was because we had a centralized mechanism, and it was requested of us to work collaboratively with our essential health service team. The other thing I did want to mention, and this is a bit off point, but you know, Andy probably spoke about the ACT Accelerator. There's the Health Systems Connector. In that, there is going to be a huge amount of work happening very soon for rolling out vaccines through the COVAX Accelerator, and all of that needs a community view. That needs to take into consideration how people will accept vaccines and where and how to deploy, etc. And I think there are going to be some opportunities there. And our goal, I guess, would be to ensure that when we know there are country-based opportunities, to share that with you, so that there is a chance for you to be in the communication and conversation. And I think what the HIV activists have done so well is make sure that they're at the table in some of these and directing the conversations, because no other diseases, and certainly not emergencies, have been thinking this way. So you've changed the thinking of our emergencies colleagues. The fact that they're saying mental health has to be a part of our first, and you know, it's not just the drugs, the diagnostics, and the IPC, it's also mental health. It's a critical piece. And I think we have to get them thinking that diagnostics, don't reinvent the wheel, use what's available. Community delivery, don't reinvent the wheel. There's so many excellent examples that would engage people living with HIV, and certainly women and girls living with HIV as well at the center. Long-winded answer to say, I don't think there's anything stopping us except for understanding what the scope and the need, and do we have pieces that are already developed that we can pull together, and are there new pieces that need to be developed, and ensuring that we have the time and the person. But two good things: US government is coming back to WHO. So for us, that means we're less, we have the view in the future that we'll have some more resources, where we've been very, very limited over this last year, at least for our department. And secondly, we have so many great tools at our hands. And if you didn't know, I just want to stick this in, it's totally off point, but yesterday we've launched a new recommendation on dapivirine ring for women as another option for long-acting prevention. So I think the other thing is to think about you know, are these opportunities that if we're COVID testing, can we HIV test? Can we share prevention modalities and sort of be more full service when we're bringing in new innovations? I don't know if that was necessarily touched upon in the conversation, but, you know, interruption of contraception, interruption of PrEP, all of these things need to be part of the response and the answer. So thank you very much. And I really apologize that I've been in and out, but really fantastic conversation. Thanks.
No, thanks, Mike. So we have about 8 minutes left, but what you just discussed was, what you just mentioned was discussed before. So, I mean, there's a wide range of things. I mean, from changing gender norms to policies to like literal interventions that have just come out, as you said yesterday. But I think the point here is that we're going to hold you accountable for at least now saying that this is not something that you cannot do. And we have very willing and able people at the table and part of the participants that are watching now that will be willing to work with the WHO to figure out how, when someone searches the WHO website and says COVID, HIV, COVID woman, COVID violence, you get no results. So unless you know where to find what, and you're able to dig through clinical reading, this is not going to be useful at the community level. And so what we're saying is we want something that the average community person can say, okay, here, I get this. This is what I can hold my local decision makers, governments accountable for. And I must make a point here about evidence. So, you know, Andy talked a bit about, yes, Chris, I will come to you shortly. Andy made a point about inclusive governance. And I know we've read up about that piece, but it's really largely understood to be, you know, the typical research-based, not necessarily the experiential community-led research or community-led monitoring and advocacy outcomes that comes from the lived experiences and from the field. So we come back to this problem again of, even I think in the document, it actually said that this was community groups and civil society were not consulted during this. So it's kind of like, so here we are, please include us so that this can be part of it. So I think as you go forward with, you know, making decisions on the next step with either documents or policies as you continue, the inclusion of community and the threshold for evidence. And we've had this discussion before. Do you need to be a peer-reviewed journal article? Do you need to be a randomized controlled trial to be able to say something that's valid? And how do we ensure that, you know, community research and the data that comes from communities can be validly have a space in the conversation? Chris, I would love for you to stop waiting on me. Continue.
No, okay, no, it's actually, you need to try. I think, yes, you need to hold us accountable, but I think we all need to acknowledge and think better in terms of understanding what is it that it's the absence of something that we haven't created, or is about not putting in place something that we know. And what exactly is the priority? Is it what is it about the policies that are not allowing for social protection to come in? What is it about the medical treatment that is not able to roll in? And what is it that is related to the medical system, and what is it about the economic system? So in all of that, I'm trying to say is that quite often is the non-application of what has already been recommended. That is the problem. So how collectively are we keeping each other accountable? That includes governments and donors and civil society and us, in terms of doing what we need to do. So I'm trying to shift the narrative, I guess, from pointing fingers to just working together and really just stop demanding or trying to justify why our rights need to be upheld. It is about demanding that the rights are being upheld. It is demanding that services should be provided, and that we, yes, communities can step in. So I'm dealing with a family emergency, and yeah, it's okay. Well, it's life, humanity. But that I think is that we need to no more apologies. Rights are rights. The world is facing 3% extinction, and we're worried about patents. I mean, that should be driving us, I think. Anyway, that's what drives me.
Yeah, and I mean, others have raised already about the need for disruption. We have been this way before. No one has raised an issue that was like so new and like, wow, we've never heard that. We didn't know that. So it's about documenting and highlighting the findings, which is part of this webinar and what we've written up. But then what's the next step, right? How much can people be expected to disrupt? Like women have to see about their children, their own health, deal with violence, but also do the advocacy, but also disrupt, but also do everything else. When and how can we actually support this? We have one person that has been waiting very patiently. I think it's Taline. Please, Taline, can you do a quick introduction of yourself, as in where you're coming from, the organization, and quickly ask your question? You have only 2 minutes, I apologize.
So I will not be saying everything I have on my heart. My name is Rita Wahab. I don't know why it showed Taline, but Taline is my colleague. We are in MENA Rosa, the network of women living with HIV in the MENA region. As a matter of fact, all over the years, the vocabulary has changed. So when we were talking about testing and treating the women living with HIV, we were wondering that the treatment itself is enough. But with the years, we now learned that it's not enough. I cannot ask a person to take the treatment, as some of you have said, on an empty stomach, or if they are facing violence at home, etc. So having the pills alone are not enough. What we need is to have a collaboration, to have a sit around one table, the UNFPA, IDLO, WHO, UNAIDS, etc., so that they decriminalize the sex work, they decriminalize the drug use, and they are giving the rights for the girls, the positive HIV positive girls, to be in a center or to be in a school, or for the old women living with HIV to be accepted in a center for geriatric care, etc. So it's not about me taking a pill. It's about me being a human being who has needs. I am an HIV positive in my childhood or in my adult years or in my old years. So I'm having children, I'm not having children. So it's I'm having a partner or I'm not having a partner. It's all these elements that constitute my life that should be on the center and on the table. It's not about only my ovaries that should be discussed out loud. It's my whole life. So am I accepted as a human being? Are the institutions looking at me as a human being or only as a key population who is at risk or who is spreading the risk? You know, it's a slight change, but for a star to glow, it has 5 angles, and the 5 angles have to be bright so that this star can be qualified. And we are talking, Jacqueline has mentioned this, that we need also to rise the qualities and the technology and to empower the women. They cannot be working as volunteers the way they are now in the MENA region. They have to be empowered with phones, with technology, so that they can reach out to other women at risk, affected or living with HIV in remote areas. So all this has to be taken care of by all the institutions, not only WHO and UNAIDS working in separate fields. We all have to collaborate the work. We all are at risk of everything now that COVID is going to be over, hopefully in 2022, but we all know that the side effects of the COVID will remain. Anxiety, disturbance in finding sleep, aggressivity, depression, they are all side effects of the COVID. We as frontliners are aware of these things because we have to pass the good and positive messages to all our ladies and all our focal points and the other frontliners. So we know that these side effects will remain. Violence, aggressivity will remain. So we are not going only to tackle gender-based violence now within the COVID pandemic, but we also have to think about it after the COVID. So please have this in mind. And we are also witnessing aggressivity and violence against children. We know that even our own women are sometimes being aggressive against their children because they are suffering from depression, etc., etc. So all these have to be covered by UNICEF, UNFPA. I'm repeating myself, I'm sorry, but this has to be a work done by all these institutions in order to alleviate and have a well-being life for the women living with HIV and for the women who are at risk of having the HIV. Knowing that during this pandemic, I also repeat the fact that the sex workers were not able to buy a condom. So they were having unprotected sex. And God knows the statistics that we will be having next year about new infections.
Yep.
Thank you.
Absolutely. Thanks very much for those points. Very well noted. We are over our time right now, so I have to wrap up. So this will be the last point here. I mean, I think we can try to see if we can get the WHO as well as UNAIDS in every session that they have to hold their policymakers at the national level to include evidence that comes from the community. I think all of the points that were raised just now by Rita were things that if we can say, hey, while you put up your stockouts, while you put up your thing, this is what the community experience is like. When you say that there are condoms for everyone, and you say, no, there are no condoms, this is the experience of the woman. When you have those stark contrasts, you then are able to hold governments accountable, particularly at the local level. So because we have to start somewhere, because we're not going to change this multinational bureaucracies tomorrow, but maybe at the local level, if we can see that. So I really want to make a plea on behalf of the women living with HIV groups that we've spoken to, and those that have been so eloquent in expressing the issues and really just sharing their lived experiences on the panelists in the first hour, and those who have been attending and stayed on after time to speak as well, to really say we're relying on WHO and UNAIDS as almost our closest friends to be able to really hold the feet to the fire with national governments. And I know to an extent you're dependent upon them, but now that we sort of live in a post-Trump era, and should I say that on recording? No, maybe not, but we have a little more hope about having a more even conversation about, okay, now this is what we need to do. So really looking forward to moving forward on the specific guidance. We are here and we would like to take some of that forward, even if it's just to collate what's already done. And as you said, sort of do a mapping and see if there's something new that needs to be added. But there is a need. It's shouting out to you. There is a need and we're willing to help. And then the second part of it is around really the evidence, because all of the things that are spoken about, if are shown up in contrast to what the government is pretending is not an issue or not seeing, then we can actually then hold people more accountable. So thank you very much, everyone, for your time. I apologize if you had a question that was not answered. We will do our best to capture this from the recording and address it and put this up as well as a recording. Thank you very much. That's it.
Thank you for having us. Really appreciate it.
Thank you for multitasking. All right. Bye, everyone.
Bye-bye. Thank you.
Bye.
Bye. Thank you, colleagues. Bye-bye.
Bye.
Bye, everyone. Thank you.